Hi, my name is Matthew Bark, and I will be looking at the descriptive epidemiology of the obesity epidemic, primarily within the United States, but also at the global level. I decided to look at obesity for this project due to its impact on comorbid conditions and the rising prevalence of other comorbid conditions, including hypertension, type 2 diabetes, and cardiovascular disease. Obesity profoundly impacts health outcomes and also one's ability to take up physical activity and other preventive health measures. This chart is data collected in the United States National Health and Nutrition Examination Survey. And this survey gathered obesity trends on a sample that was selected at random, however, is representative of the entire United States population. This table shows obesity prevalence stratified by demographic characteristics reflective of the entire US population and also adjusted for age. This table reveals no statistically significant differences in obesity prevalence between males and females, as indicated by virtually equal prevalence percentages between the two age groups. Across both sexes, obesity prevalence was highest amongst adults aged 40 to 59, and a statistically significant difference in obesity prevalence was seen for men in that age group as well. Black Americans had the highest obesity prevalence among all race and ethnicity groups, with statistically significant differences being seen in the data between Black Americans with both white and Asian Americans. The middle income group measured had the highest prevalence of obesity in the survey. And with respect to education, having a college degree or more greatly reduced obesity prevalence among that population. This slide shows how obesity prevalence has changed over time across all age groups. Looking at the graph, you could see a gradual increase in obesity prevalence over time across all age groups, according to the National Health and Nutrition Examination Survey. The survey showed that the greatest increase in obesity prevalence occurred among Americans aged 30 to 39 years old, although similar increases were also seen among Americans aged 20 to 29 years old and aged 70 plus. The upward trend amongst all age groups indicates a growing incidence of new obesity cases across the US. And the fact that the incidence is rising in every age group shows that all people are at risk of obesity, no matter what their age is. This slide shows sex-specific obesity trends with respect to time, gathered by the National Health and Nutrition Examination Survey. Over the past 2 decades, male and female obesity prevalence have both trended upward. However, a much greater incidence was seen in males, pointing to a greater proportion of new cases. The slope of these trends in these graphs can be described as the incidence rate, given that time is an independent variable in the graph. The similar prevalences seen in 2017 to 2018 between males and females are consistent with the results shown on slide 2 of this presentation, also gathered from the National Health and Nutrition Examination Survey. This slide shows obesity trends with respect to different races. It's important to note that the National Health and Nutrition Examination Survey did not begin to measure obesity prevalence for Asians and Hispanic Americans until data collection was already underway, with Hispanic obesity prevalence being collected starting in 2007 and for non-Hispanic Asians starting in 2011. Looking at the data, Mexican Americans had the greatest increases in obesity prevalence along with whites, and the incidence rate was extremely similar for these groups from the beginning of data collection for Mexican Americans in 2007, as indicated by the virtually equal slopes during this time frame. This data is consistent with the prevalence data in slide 2 from the National Health and Nutrition Examination Survey, which showed the highest obesity prevalence among Black Americans and Hispanics. Research has shown less statistically significant differences in obesity prevalence across different religions. However, there is a trend across all religions in which those who are stronger believers have higher obesity rates. This is likely due to cultural practices. This slide shows socioeconomic implications of obesity and risks. Looking at the data, socioeconomic status is an important determinant of health and directly impacts the health behaviors of individuals as seen in the different mean BMIs between different factors. Those with lower socioeconomic status had significantly greater BMIs, as shown at the top of the graph. College education significantly reduced obesity prevalence and lower average BMI, the indicator in which obesity is diagnosable by. The clinical definition of obesity is having a BMI of 30 or above. Those below the poverty level had greater BMIs than those above the poverty level, which is consistent with the National Health and Nutrition Examination Survey data shown in slide 2. Lastly, looking at the bottom of the chart, those with access to private health insurance had significantly lower average BMIs, which is indicative of lower obesity rates. There are less studies that stratify obesity rates by occupational category, although it is known that there are occupational exposures and risks that influence obesity amongst certain professions. Studies measuring obesity trends by occupation found that the healthcare industry had the greatest proportion of obese workers at a 30% prevalence. With respect to race, obesity differences were the most significant among higher ranking positions. This is likely due to elevated stress that is exacerbated by differences in race. Another study focusing on older Americans saw that the highest rates of obesity among women came in operator and laborer positions. Meanwhile, amongst men, professionals and farm workers had the highest obesity rates. Professionals refers to lawyers, doctors, engineers. When looking at obesity with respect to marital status, studies widespread have shown a greater prevalence among individuals with a spouse who is obese. Spousal BMIs tend to increase or decrease adjacently, which points towards a greater risk of incidence of obesity in healthy individuals who have an obese spouse. In the United States, the greatest risk of obesity was seen amongst married men compared to single men. However, married women had an opposite effect with a lower risk of obesity while married. These trends were consistent across all racial groups. One past analysis looking at the data from the National Health and Nutrition Examination Survey revealed that the greatest obesity rates were among high-income married Black men. This means that the high income, the married, and the Black racial group are all top risk factors for obesity based on this analysis. This shows obesity on a global scale. Obviously, obesity exists in all countries at different prevalences. When looking at a world ranking of the most obese countries by prevalence percentage, the large majority of countries are in the Pacific region of the world. This is likely due to different cultural practices. This map depicts a greater average obesity prevalence in the Western Hemisphere compared to Africa and Europe, as shown by the greater proportion of blue on the left of the graph. The United States is considered the most obese high-income country in the world, with Australia also being considered a country that is relatively obese for its high income level. You can see Australia and United States both are very dark blue. indicating a high obesity prevalence. This graphic shows obesity prevalence in the United States. In the United States, the Midwest and the South have the highest obesity prevalence amongst all regions. This is seen on the graph as most of the red indicating higher obesity prevalence is found amongst southern states. It is important to note that all states had an obesity prevalence of at least 20%, with these prevalences expected to rise in the coming years. This means that every state has at least 1 in 5 of their population who is obese, which proves how important and large obesity is as a problem and an epidemic. Studies have shown that one's physical environment also has a profound impact on their risk of developing obesity, whether this be through food availability or the facilitation or impedance of physical activity, which reduces risk. One meta analysis examining over 500 studies found a significant direct association between the built environment and obesity in over 80% of the studies that were analyzed. Other studies have shown similar results, as walkability has been shown to profoundly reduce obesity risk by increasing physical activity and other prevention behaviors. In terms of biological risks of obesity, a family history of obesity significantly impacts one's risk of developing obesity throughout the life course. This can be partly attributed to genetics, as studies have found genes linked to hunger and metabolism more prevalent in obese cohorts. Also, endocrine disrupting chemicals in everyday products, cosmetics, and even processed foods can also elevate one's biological risk of obesity due to its impact on fat metabolism. Populations with greater exposure to these chemicals have been shown to have significantly elevated obesity rates. In terms of social risks to obesity, obesity rates have been consistently elevated in areas with higher crime rates. These are typically the same communities experiencing deprivation, resource disparities, food shortages, and other problems, which exacerbate financial difficulties among families in obtaining healthy food options. Studies conducted on various mammal species have also revealed greater obesity rates among lower ranking counterparts in the social hierarchy, which does exist among the human population due to socioeconomic differences. Another social indicator of obesity prevalence and risk, as described earlier in the presentation, is education level, as college graduates have the lowest prevalence of obesity, indicating that education serves as a preventive method to obesity. Thank you so much for listening to my presentation. Here were the references that I used in my data collection. Most importantly, data from the National Health and Nutrition Examination Survey. I accessed um, interactive data visualizations through the CDC, which had up-to-date and full summaries of the National Health and Nutrition Examination Survey data used in this presentation. Thank you again.